Welcome, everyone. And now we'd like to welcome and introduce Esmy Jimenez, our first keynote speaker, who will speak on breaking silos and reimagining behavioral health, building a connected future. Welcome, Esmy.
Hello.
Esmy Jimenez is a senior reporter for the Boston Globe, currently investigating the racial wealth gap. Starting as a local NPR correspondent in rural Washington, Esmy later joined Seattle's KUOW to cover immigration under the Trump administration, earning a regional Edward R. Murrow Award and Public Media Journalism Award. She has worked with the Seattle Times on mental health reporting, launching the Lost Patients podcast in 2024. A first-generation high school and college graduate, Esmy is also a past president of Periodistas Northwest, a chapter of the National Association of Hispanic Journalists. If you have questions for our speaker, please enter them into the Q&A section. Questions that are posted in the chat will not be relayed to the speaker, so really make sure you post them in the Q&A section. All right, Esmy, I'll let you take it away. I'm really looking forward to hearing what you have to say.
Thank you so much, Lauren, for that. I really appreciate that. And thank all of you for being here. I'm Esmy. I'm really excited to be here, and I'm flattered that many of you are here. I know many of you actually, both presenters and people in the audience, because I'm a fangirl of you. I've tried to interview you guys. I love the work that you do, so I'm very, very excited to be here. And for those of you who don't know me and are like, who is this lady? Don't worry, I'm about to tell you. And then let me also just quickly describe myself physically for any folks. I'm 31. I'm a Latina woman. I have wavy, curly, dark hair. It's not too frizzy today. And then I'm wearing a white button-up. So currently, as mentioned, I'm a reporter at the Boston Globe. I just moved there this spring and hit 6 months. If you have any strong feelings about Boston, please put them in the chat. Lord knows that my friends and family had feelings about Boston. So anything that you have to say in there, you can definitely say it. You can't hurt my feelings. I've seen it all. Otherwise, if you have recommendations or things to do here, people to meet, stories to write, you can also put those in the chat. As mentioned, I was at the Seattle Times covering mental health for 2.5 years. Before that, I was at the public radio station called KUOW in Seattle. I was covering immigration and COVID and even the protests. So I've done a lot of work over the last 8 years as a reporter, mostly in the Pacific Northwest. But I figure I also really want you to know me. If I'm going to have the honor of having an hour of your time, I'd like you to really know who I am as well. Oh, and then before I forget, we do have a Q&A at the very end of this. So we'll have about 10-15 minutes for that. But you're also welcome to drop questions in the chat. You can drop jokes, memes, reactions. This space is for you as well. So give it to me. But all right. So other things that you should know about me are that I've lived many other lives. I was in Alaska actually fishing for 2 summers on a commercial fishing vessel. I was fishing reds or sockeye salmon. This is when I was still a kiddo, you can tell. And then I was a state park worker for the California State Parks for a summer. I was a barista for many years in Los Angeles and Seattle. And when I was first trying to freelance, I was working as a barista as well. So chances are, if you were ever in the Seward Park neighborhood in Seattle, chances are I made you a latte at some point. So that is another reason we perhaps have connections. Besides this, I've also done data work. I was at a couple nonprofits. I even joined a law firm for a little bit before I really landed my first reporting gig. But I really care about stories, and I care about the stories of people. So this is why I worked so hard to get into journalism and why it matters so much to me. So yes, 8 years later, I've been in 4 different newsrooms, done lots of collaborations, breaking news. This will be my 3rd presidential election cycle. Now I have gray hair coming in. I'm sure it's a winning combination of stress and time. And most recently, some of you may know my work on Lost Patients. It's a 6-part investigative podcast examining the mental health care system in Washington and a large part of the US, honestly. So we hear from people who've experienced psychosis. We talk with family members trying to get their adult children care. We actually even go back in time and we look into the closure of Northern State Hospital back in the 70s. And I'm telling you all this because I know a fair bit about our mental and behavioral health system in King County and Washington, especially as it overlaps with the criminal legal world. And I realize a lot of you that also work in this. Some of you, like I mentioned, I've interviewed, or I really want to interview you. Many of you gave me ideas or pointed me in the right direction of people to interview, topics to cover, and just to have a better scrutiny of what was happening in the King County area, in the Washington area. So I'd like to acknowledge that even though this is my byline, my face up there, of course, it's your expertise that I try to highlight. It's your stories that I really try to center, because you are the folks that know a lot more about this. So I'm very flattered that I got to come here, but it's just very, very important for me to say over and over again, like, the experts are already in the room. I'm just here to hopefully learn a little bit more from you, share what I've been able to learn in the last few years about covering mental health, because it is a slightly different perspective. But then hopefully just being in really good conversation with each other. That's really my goal for today. All right. So the ways I thought about it is I would like to give you kind of 3 different buckets, or 3 different stories here, if possible. One is going to be about Adam. He's Adam Orend. He was in our podcast, Lost Patients, and he was also in an article last fall. And it's okay if you don't know about him, because I'm going to tell you about him right now. And then I'd like to share 2 pain points that I've seen in our current mental health system, based on a couple of stories that I've produced in the last couple of years. And then I'd like to end with Erin, a social worker in Mount Vernon. And so I have a video to show you about her work as well. All right. So first up, Adam. Adam is a 40-year-old man. He was born in Georgia, but his family moved to Portland, Oregon. And actually, rather than just talk at you, I'm going to play an excerpt from one of the episodes of Lost Patients. I don't have the transcripts, but you should hopefully be able to get closed captions if you have them already on your device.
As a kid, like 6, 7 years old, he'd go get lawnmowers that adults had given up on, put them back together, and they'd run.
Adam Orend wanted to fix things. At Heidi's house in Portland, on the mantle, she has a photo of Adam as a grinning little kid lying underneath a tricycle that's propped up like he's a mechanic working under a car.
That is Adam. He was 2 years old, and he was working, or he was probably 3. He was working on his big wheel. He was going to fix it.
Adam's little sister, Bethany, remembers him accumulating a junkyard of broken toys in their yard in small town Georgia.
My brother would go get Power Wheels that other kids had thrown out or whatever. He was going to fix them. He was going to fix them all for me so I could have a Power Wheel. And when they didn't run, he would push me in them.
Through the yard. Adam had a leg that turned out 180 degrees at that point. That was before surgery. And he literally had a hard time moving. And he was in that backyard just pushing her all over as if it just was nothing to him. It was just, he doted on her.
Heidi says some of Adam's knack for fixing things came from his dad, who taught him how machines worked. But Adam inherited something else too, his father's brittle bone disease. Adam spent his childhood in a body that broke easily.
We let him ride bikes, and a kid went in front of him, and he went over the handlebars, and he broke his hip, his pelvis, his arm, his wrist, his face. There's a picture over there of him walking with his cane. He had a walker for a while. He had a hard childhood. He had a hard life.
Adam's parents split up when he was young. Heidi eventually settled in Portland with her 3 kids. Along the way, Adam held them together. He was quiet, grounded.
He was the middle child, and he was the glue.
Adam made money doing body work on cars. The way his mom and sister talk about him, it's almost supernatural how good he was at anything that required patience and precision. There's a video of Adam and his older brother, Jason, jamming on instruments at Seattle's Pop Culture Museum. Adam's on guitar.
He could pick up something and he could learn how to fix it or learn how to play it or learn how to train it or whatever. And he had the patience of a saint.
Adam could train a dog without treats, without harsh words. He just was one with the dog. And he didn't even say, come. He just made a noise and the dog was right to the side.
On one of the Facebooks, it has a picture of a car Adam redid. It was rusted out. It was not running. It had no engine, nothing. And he redid the entire car. I mean, from the bottom to the top, it was cherry coated, painted. It was meticulously done. And he had such finesse with his hands. And he took pride in everything. So to see him go from that to this downward spiral.
Something changed when Adam was in his 20s.
All right, so that was a part of episode 1, Churn. So sorry if you hear any loud noises. There's unfortunately construction right in front of my house today. Incredible timing. But so we were just hearing this episode about Adam, and I learned about him because his mother Heidi and sister Bethany reached out to me about their experience with the mental health system over 8 years, trying to get care for Adam. So over several months, what I did is I started looking for his paperwork, and I found about 400 pages. And that included municipal court records from 3 cities, including Everett, Marysville, and Arlington, state records from Oregon and Washington State, prison records from the Monroe Correctional Complex, hospital records from Swedish and Harborview Medical Hospitals, and then records from Western State Hospital, where he spent almost a year in the forensic unit. Adam was released from Western in early 2023, right into homelessness. And I'm really sad to share that he lasted only about a month before he died in early March 2023. Now, for me as a reporter, I wanted to understand, why did Adam die? He had the support of his family, his mother, sister, brother, and an uncle. He actually went into a treatment for a little while. He was going to a methadone clinic in Shoreline. And he was screened for mental illness in jails. In 2015, a counselor flagged his case for a mental health screening. The counselor said Adam appeared to be currently suffering from symptoms of mental disorder, but the counselor also found he could understand legal proceedings well enough to assist in his own defense. So Adam didn't actually end up in treatment, and said he was jailed for a month and fined $600. Now, during his time in prison, Adam was also on multiple antipsychotic medications, and he was in a specific unit for people with severe mental illness. He turned to the ER multiple times at different hospitals, seeking food and shelter. But he seemed to be caught in the churn, right? This constant revolving door where he just bounced from one spot to another. In Seattle, I looked up how many folks are in this kind of situation, and I learned that the city attorney's office keeps a list of about 168 people who are like this. It's technically a small group of people, but they have an outsized impact on behavioral health resources. For years, local governments and health services have struggled to figure out what to do with this group of people. It seems to me that the approaches often ping pong between harsh enforcement policies and jail sentences, or in some cases, therapeutic programs that can help some individuals, but have failed to get the political backing, scale, and resources needed to really be effective. And then while there's therapeutic courts that are popping up to divert some people, many people don't qualify for the programs. Sometimes the person's charges are considered too severe, or they actually lack the mental competency because of their mental illness, so they cannot agree to the requirements of the program. Even when someone actually makes it into one of these diversion programs, what I also notice is that they often face these other interconnected challenges, whether that means actually not having housing, so that they're not able to get mail, transportation, they can't physically get to the courthouse, or medical needs, which make them really vulnerable. So to me, this speaks to a massive hole in the mental health world, which is that for the most vulnerable patients, the ones that are complex because of dual diagnosis, medical issues, what have you, they're the ones that are most likely to fall through the cracks. And I will say for Adam, a lot of things went wrong in covering his story and having some space from that story, which I think first came out last year. I realized, like, you know, there was a lot going on with him, right? Both the severe mental illness, substance use. He had burned through family at one point. He'd already churned through the mental health system for years. and he has the brittle bone diagnosis, so he's medically vulnerable. But for me, the other thing is that what happened to Adam is not also entirely like a mysterious, super nuts problem to solve. The reality to me was just that he had nowhere to go. When there were criminal allegations, jails would detain him, right? And then emergency rooms would hold him for the mandatory time that was necessary for an involuntary hold when he was really, really sick. But when it came really to it, there were few places that could actually house him long term with the necessary resources. And to me, that's what would really help him recover. That's what would have helped him figure out if he could work or go to school one day, the kind of resources that could invest in his well-being, not just for a couple of weeks, and not just based on whether or not he had the right kind of insurance, but really investing in what would be a lifetime of recovery. And as you know, we have very few of these places that are really equipped to care for the most vulnerable people in our community. And the other thing that I've noticed is that even when we do have some of these available facilities, those facilities are the very ones that sometimes turn people away. One of the other things that I noticed in reporting on this for the last couple of years is that there are a lot of different little spots where there's a lack of communication. And let me give you an example. I'm being vague, but specifically in 2022, I had talked to the former director of the King County Behavioral Health and Recovery Division, and I learned that the county produced this report. This report found that about a quarter of patients in our region were getting turned away from what are called evaluation and treatment centers, aka inpatient units. So hopefully you can see this well on the screen here, but Cascade, Fairfax, and Navos were chief among those declines. And now the declines occurred for a number of reasons. Some of them might be medical needs, meaning that the patient needs a higher level of care than what's available in the unit. Sometimes, though, that means just their blood pressure is high, they have a CPAP machine, they have a wheelchair. These were things that were documented in the report. The second reason why people were declined was behavioral issues, meaning perhaps that person had a history of being combative, perhaps they also presented with cognitive or intellectual disabilities. The third reason why people were declined from facilities were administrative reasons, meaning there were staffing issues or perhaps staff was trying to balance the acuity on the unit. And then the fourth reason actually behind all these three was then a lack of beds, which to me was frankly pretty surprising. Often what we hear, not just in the media, but when I hear parents or family members talking about accessing resources, we hear there's just not enough beds. And that's definitely partially true. But there's all of these other factors that make it harder for people to access care, even when there are beds. And some of these are good reasons for declining someone, I'm sure. But at the end of the day, I've also, in hearing how families actually navigate that maze and knowing that they have to figure out when is going to be the right place at the right time that they can get their loved one to get care, that is also incredibly stressful. When talking to parents and families, they liken it to having like a hot potato situation where their loved one is just being moved around and no one seems to quite want to be able to hold them, but they do have to go somewhere. So the other point that I like to get to here is that for our county officials, DCRs, when they're calling around to try to get their patient connected to care, that means they're calling each one of these facilities as well, one by one, hoping that there is a bed open and that everything works out. That to me is one huge barrier, a glaring spot that could be patched up. And so my question is, what do facilities need to be able to accept more patients? What do staff need? What kinds of training or resources would make these facilities accessible even for the Adams of the world? How do we make this maze not so complex so that people don't get lost in it or fall through the cracks, but that they can actually be connected to care? This brings me to my second bucket of stories, if you will. And I will say these are a little bit trickier because they include violence on healthcare workers. And I don't believe anyone should have to face violence at work. But in Washington, it's especially tricky because if a patient or someone in crisis slaps, spits, or in any way physically impacts somebody, staff are protected under state law. And so what happens for that patient is that they often end up with a felony charge. It's not just a misdemeanor. If this had happened in a public place in Seattle, if imagine I had spit on someone in Seattle for some reason. That would be a misdemeanor and it would be gross and bad. But if it happens in a healthcare setting, it is escalated automatically to a felony level. So my colleague, Sydney Brownstone, and our friend, Chrissy Thompson from the Marshall Project, we teamed up together to go through about 5 years worth of cases. These are called assault threes. That's the formal like RCW language for it. Because we wanted to find out, well, who's getting charged under the state law? What is really happening under the hood, if you will? And here's what we found. So from 2018 to 2022, King County prosecutors filed 151 cases for felony assault on healthcare workers. Court records show that 76% of these cases were filed against people with signs of serious mental illness. That included people who were involuntarily committed to a psychiatric facility, who were in an emergency room for a mental health evaluation in the first place, or in cases where EMTs were responding to someone in a mental health crisis. 40% of the people charged with this kind of felony assault were also described as Black in police records. This is an even higher racial disparity than overall felony cases in King County, where roughly already a third of defendants who are counted are listed as Black. And then as a reminder to anyone, our county's population for Black folks is 7%. The other thing to note about these assault cases is that they can be really difficult to actually prosecute because of competency issues. So whether that person understands the charges against them, whether they can assist in their own defense, most likely because of their mental illness that's not being treated. So my colleagues and I also looked into that, and we found nearly 40% of the cases that were brought up were questioned in court when it came to that person's capacity to actually stand trial. And I know most of you know this, but when it comes to felony charges like this, if someone's not competent to stand trial, what happens is that person is going to be sent to restoration treatment, and that occurs at a state facility. The reality, though, is people can spend weeks or months waiting in jail to get into a state facility. And meanwhile, they are still getting sicker. They're decompensating. They're going without treatment. This is to not get too lost in the sauce and get into the weeds. This is more of the True Blood settlement. I'm not going to go too much into that, but I can tell you, we've had cases, I've read about cases, I've written about cases where someone is spending more time waiting to get into restoration treatment at a state facility than if they had just pled guilty in the first place and spent that time in jail. That's what we're really looking at in Seattle and in Washington State. Now, to make all of this much worse, it's also incredibly expensive. We talked to the County Office of Public Defense, and they estimated that for each one of these cases, all 151 of them, mind you, taxpayers spent nearly $5,900, it's almost $6,000, in attorney fees to actually defend every one of these cases. And mind you, this does not include jail fees, transportation, the actual costs of the public hospitals or the state facilities. That's just for the actual legal fees. And some of you may be thinking, okay, but we also have mental health court. We have all these alternatives to the criminal legal system, right? We do have those, but they're actually much trickier to get into than you might expect. Of the 150 some cases we analyzed, only 6 people were accepted into what's called LINC. It's the Legal Intervention and Network of Care program. And then another 6 of these cases were handed off to actual mental health court. And the reason why it's so tricky for people to actually access these diversion programs is because many of the programs require that the defendant opt in, like very specifically opt in, which they might not be able to do in the first place because they're already sick. The other reason is that someone might already have what's considered too serious of a background or too serious of a criminal history. And so they might not be allowed to enter these. For felony cases, like in assault threes, they are mostly not eligible for a lot of the diversion programs. Those are only for misdemeanor or lower levels. And then if someone's primary diagnosis is substance use disorder, they're also most likely not going to be eligible for any of the diversion programs. And altogether for me, this just means there's another massive hole here when our criminal legal system overlaps with our mental health system. And then I have one more example of that as well here. Actually, no, I don't. Just kidding. I've been talking about everything that's not working in our current mental health system. And I want to also be cognizant that there are things that do work. And so I want to move on to this third section of stories that I'm hoping to tell you about. This one is actually about Erin Von Femp, who is embedded with the Mount Vernon Police Department. And I'm just going to go ahead and play it for you guys. I didn't do this one. My colleague Hannah Ferfaro on the mental health team, who is still there, did this for the Seattle Times about a year ago.
No one grew up saying, I want to be a drug addict and a transient. If you can tap into people's authentic selves and help them remember that they matter and that they have gifts to give the community, maybe they can see the change and have some hope. It's pretty hard to have hope out there. I'm a licensed clinical social worker embedded in the Mount Vernon Police Department. This position was created to work with people without homes and help them access services and find housing. I make appointments for all kinds of things, doctor's appointments, mental health assessments, substance use assessments, attorneys, trying to figure out where the barriers are for them to have a better life. That's a huge part of the whole thing, is having a relationship with somebody. I mean, that's how people trust you to try these new scary steps. Hi, you're here. Yay! In this county, there wasn't any other embedded mental health professional in a law enforcement agency. And then law enforcement officers, their jobs aren't to help someone access substance use disorder services or mental health services.
They wouldn't give me my meds and I ended up back out here, so I didn't.
Many times people will talk to me. It's best if I have the opportunity to sit down with somebody for coffee or something like that, and they can relax and tell some of their story. But it's just about trying to figure out how I'm valuable to them. If you had the opportunity to stay in a motel, how do you think your life would be different?
I would be able to get involved with services and volunteering and stuff then. So I would be stable. Right now, I'm not.
We have an opportunity to offer very few people a motel room for up to a year. You have to be a good neighbor, and we'd like to help you work on all those things that you listed. Would you be interested in that?
Okay.
Yeah. A lot of people have had huge traumas in their lives, and that has made them more fragile and vulnerable. And then they have addiction problems, or their mental health problems flare up, or they haven't had the support that they wanted, and they end up without homes. And there's so much healing that has to happen for them. And they would like to talk about their trauma and their issues, and work on their emotional healing, and find a place to belong. Thank you. Okay. Throughout my career, I've known that I'm important and not important all at the same time. I'm a placeholder for people. I can be a person that matters in their life. And then eventually I'm a person who doesn't matter in their life. And that's like the best success, really.
I can say I told you.
You did. Good job. Okay, thank you.
Okay, Erin, thank you so much.
I'll talk to you soon.
All right.
Okay.
And I really wanted to show you that because, oh, here's my dog. Sorry about that. I really wanted to show you that because I think often in the news, we don't have a lot of good news. And so what we also really try to do in our first 2 years of covering mental health was actually bringing more stories of things that do work, or even just the intimacy of what the work looks like. While you guys see it every day, the majority of the public does not. Families don't necessarily see it from their perspective as well. And then a lot of lay people just don't exactly know what's occurring, why it's occurring, the laws, the different regulations of each facility, things like that. So it's been really helpful for us to be able to be like, here is a way to bring humanity and a little positivity to all of this that's occurring. Here's another example from that as well. This one was a really fun story to do. I was able to go down to Arizona with a bunch of legislators a few years ago, and we were actually able to go to crisis facilities in Arizona that were very, very different from what I had seen here in Seattle. To me, this is one of the success points that really needs to be highlighted more often and for more of the public to understand as well. So the Arizona model, for those of you who may already know, maybe don't, it's completely different, but it starts with this key philosophy, and that's that there's no wrong door into the mental and behavioral health world. Whether a person has mental illness, addiction problems, intellectual or developmental disabilities, all of the above, everyone gets to access services at the same place, same time. In Washington, by contrast, patients have a hard time finding that help between specialized facilities. The ER, jails, and the community. People with criminal or complex backgrounds are often turned away from facilities or struggle to find an available bed, especially if their insurance doesn't cover services or if they're underinsured or uninsured. So that means that they go often through without treatment and cycle through the system all over again. The crisis system in Arizona, I noticed, was also partially staffed by peers who have firsthand experience with mental illness or substance use disorder. When I talked to one of the staff at the center there, they let me know about 60% of the staff identify as such. Arizona's integrated crisis system, which granted they have been building for decades, includes the mobile crisis teams, a hotline, and a crisis centers where people can both walk in or the family members can drop them off. The mobile crisis teams can drop them off, and law enforcement can do this as well. And this all typically happens within a matter of minutes. The reason why police trust and can do this is because typically when they drop someone off, it takes less than 10 minutes for them to actually be able to do all that paperwork. Maricopa County itself also has this interesting system where they built out 3 different facilities and they're dispersed throughout the county. So regardless where you are, it's supposed to be about a 20-minute drive to get there. And I'm telling you this as well because partially this is what hopefully the new King County Crisis Response Centers will be partially based off of. And because I also think, again, we should be talking more about things that do work. Why do they work? How do staff feel there? What kind of resources and training did they get? What did it look like to build the infrastructure to create these models? And what is still necessary in these models to keep improving? One of the things that I hope that you can take away from this as well is that I'm hoping that you will be able to engage in another symbiotic relationship, which to me is actually with the media. That means not just reaching out when things are bad, but also reaching out when things are good. I'm really hopeful that we can also highlight profiles of people, medications that are coming. The UW has incredible research, which we also try to tap into, or my colleagues, I should say, try to tap into now to cover all the stuff that's occurring here. And then I actually wanted to see, I see a lot of chat stuff coming in. Would it be okay if we go to that? I know it's a little bit early, but I'm just seeing so many things coming in. I'm kind of curious. I don't know if Lauren is here, but she was our moderator. Here's one question I see. Would a person like Adam have benefited from the new crisis care levy facilities once they are open? They will allow walk-ins and up to a 14-day stay. Oh, there's Lauren.
Hi.
Lauren, sorry, I was seeing so many things going off there, and I was like, I just need to know what's going on.
For sure, for sure. Go ahead and answer that first question that you just read. Yeah.
Yes. So thank you for this one. You know, it's hard to say because Adam's no longer with us. I think it would have been helpful, especially if we had that system like in Arizona, or rather than an individual navigating that maze by themselves, especially if they're alone or not medicated, they don't have family assistance, someone else can help them navigate that. I think what was surprising to me about Arizona was this idea of The staff will do that work. We'll figure out where you need to go, the right place, the right resources to connect you to. You shouldn't have to memorize, 16 acronyms. You shouldn't have to figure out all these other things. Rather, it's just something that we can help you figure out where you're supposed to be going.
Great.
So yeah, I'd like to think that Adam would have been served by this kind of facility. Sorry, go ahead, Lauren.
No, thank you. I'm not sure if you were looking at, so we have the Q&A, and then I know the chat is also going. A lot of people are very active in the chat, but I'm going to go to the specific questions that were submitted.
Yes.
So someone is asking, is this true of people with cognitive disabilities or who are neurodivergent? Are they charged with a felony during a meltdown?
That is a great question. We were not able to necessarily break that down by neurodiversity or cognitive disabilities. What we were doing is just reading through the court transcripts, reading through 911 logs, anything that was in that person's case file. And so that's why we were able to be like, oh, this person has a history of substance use, or the 911 dispatcher says they specifically were called because this person seemed to be having a mental health breakdown or some kind of psychiatric crisis. But I don't necessarily know that information for sure. That's definitely something that my colleagues and I can look into, because I know that is something that can pop up with folks with autism, and maybe police are not equipped to be able to talk to them or essentially help them slow down when they are in crisis. But that's an excellent question. Thank you for asking.
For sure. I also see a question. Someone is asking if they can get a copy of the data presented in this training. All of the presentations will be available about a month after, but as far as like the specific like stats and data in this presentation is like a printout. I think I'll let somebody else address that in the chat and let you all know what exactly you will get besides the recordings of the presentations.
Yeah, that's true. And then Lauren, I think I can also, if at any point anyone needs access to the Seattle Times, please let me know. At the very best I can, or at the very least, I can get you like a PDF of a specific article. Obviously, if you go to the Seattle Public Library, that means you can access the newspaper for free. Often the schools, the universities have logins as well. So that should be one option. All of these are already available on the Seattle Times website, and you can find it in the Mental Health Project. That's the label for those.
Great. Thank you, Esmy. All right. Let's see. The next question. Another question came through and covered it up. Hold on. Okay, great. What are silos in this context? Oh, did I lose Esmy?
No, I think you can hear me okay.
Oh, okay. The screen just changed that I didn't see you anymore. All right.
No, that's okay. What are silos in this case?
Yes.
Well, to me, I see it as any spot where there is not immediately like a warm handoff to me, frankly, because I think for the person navigating that system and the families, it's effectively a silo, whether that's just staff not communicating across departments in the same hospital, whether that's two distinct hospitals in the way that they manage people, how they triage folks, how they intake folks, how they discharge folks, whether that's the state and county systems and the city systems that often don't talk to each other. That blows my mind. With Adam's case, one thing that comes to mind is, so he's discharged from Western State Hospital, right? He was there for about a year. He is discharged to the Bread of Life mission, and this is a homeless shelter in the Pioneer Square neighborhood of Seattle. The Pioneer Square staff, I talked to them, I went into the space. They had no record of Adam ever staying there. And so I asked them, and I was able to ask them a little bit more, like, did you know this was happening? And they were like, no. Sometimes we know we get like 3 or 4 people a month who are dropped off by Western State Hospital officials, but we don't have any of their information. We don't get access to their medical records. We have no idea what kind of history they're presenting with. We know people are showing symptoms of talking to themselves, or maybe having delusions or having quirks around them. And they will try to take everyone they can at that shelter, luckily, but they're also not a permanent supportive housing facility. They don't have medication on hand. Most of their staff are not social workers. And so they're just cognizant, like, this is not a hospital. We can't provide hospital level care.
Right.
And so that's one thing that comes to mind. Any spot where there's just that friction, that's a spot where someone can fall through the cracks, in my opinion.
Thank you for clarifying that. The next question is, do you keep track of how many hospital workers quit because of injuries from violent patients, and how many other staff quit from witnessing the violence?
So I myself have not kept track of that. We did talk to multiple unions and then multiple staff for that story with the Marshall Project about staff. And I thought staff had some really interesting insight and nuance where they were aware they're already doing really, really good work. They care about people in crisis, and that's why they're doing this work. I absolutely believe that. And people, again, should be able to be safe at work. But the reality is, because of the way systematically that the mental health system currently overlaps with the criminal legal world, you just have this little vortex where things can become worse and worse. And so for me, it's not just about figuring out, to me, it's about figuring out like what can be done to kind of undo that vortex. Is there any positive cycle that can be started, right? Whether that means having more staff in the unit, whether that means more training, more resources. I know some of the programs in Arizona, and having visited them, I'm used to having toured hospitals in the King County area or at Western State Hospital. And of course, sometimes they have this, they're not like plastic, but essentially like the nurse's unit is closed off for their protection. Mm-hmm. And in Arizona, I noticed that they didn't have that. And I kind of asked the question, like, aren't you worried about your staff getting hurt? And they were like, no, that doesn't happen as much here. And I was like, wow. Why not? That's interesting to me. And they're like, well, actually, most people end up, even if they come in involuntarily, say a person in crisis gets dropped off by police, and they're coming in involuntarily, often they have about, I think they had said a 70% switch where patients end up deciding to stay voluntarily, which really brings down then their acuity in the unit in terms of people lashing out, in terms of like being able to have comfortable staff, like a comfortable milieu. That to me was really fascinating. And so that's really what I'm trying to get at. At no point am I ever hoping that nurses should just have to put up with this or that staff have to put up with this. That's not acceptable at all. I don't think anyone wants that, frankly. But to me, the question is like, what would it look like? What would it take to undo that kind of pernicious cycle there?
Absolutely. The next question, is it difficult? It is difficult to imagine a landscape in which people seeking support for behavioral health issues or for their loved ones will find the form of support that best suits them before crisis. What are the biggest obstacles to changing this?
Ooh, this one's interesting. Let me think about that one. I see it here.
Yeah.
Chance. It's difficult to imagine. Oh, thank you. That's really helpful. Difficult to imagine a landscape in which people seeking support for your health find a form. I think there's a couple of different obstacles, but I think some of those are getting better. What immediately comes to mind actually is just that I think for better or for worse, the pandemic shifted the way that people think about mental illness more and more. I was just at a panel earlier this week, and I was reminding folks like 1 in 5 means 1 in 5 here, right? That means 1 in 5 people. This comes from like the National Institutes of Mental Health that estimates about 1 in 5 Americans have a diagnosable mental illness. And granted, they're mostly reflecting on anxiety and depression. But I think in having these conversations about anxiety and depression, it also opens up the door to talk about more severe mental illnesses like schizophrenia and bipolar disorder. And I think in starting to kind of almost normalize these conversations, we can have people speaking up more and more about it. The other thing that I've noticed is that as soon as I tell someone like, hey, I have someone in my family who has a mental illness and who's been to prison because of it, they're like, oh my God, that happened to my nephew, or like that happened to my neighbors. Or in Adam's case, speaking back about lost patients, Heidi realized her father actually also had schizophrenia. And that was something the family didn't talk a lot about. And so I think while there are many obstacles, one of the first things, as silly or as pithy as it sounds, is having this discussion more and more, having opportunities where people can talk about the really hard stuff, not just the easy stuff on top, but everything else that's uncomfortable, but is necessary to discuss so that we can get a little bit further along. Because how do we even have conversations about budgets or policies or what specific things we should be doing at a really high meta level if people are not able to at least start with the really easy, not easy ones, but the very first step of just acknowledging, here's what's happening to me, here's what's happening to my loved one, here are the barriers that I'm facing, here's what would make it easier for me. When I think of Heidi, Adam, and Bethany, their family, right, one of the biggest things there was just that you were working across 2 states. You had multiple jurisdictions. At any point, it was a police from, I think, Auburn at one point. You had Seattle City Police at one point. You had state officials. And so he was just going through all these different little crooks, and he just didn't know how to get out. His family didn't know how to navigate it. And I've had this happen too with people reaching out to reporters asking them, hey, what can I be doing for my loved one? Where do I turn to? And we try to create some of these guides, whether that's about how to call 988 or how to engage in some other kind of immediate crisis help. But in reality, I don't know that reporters, this has been the first time that I've had to engage in this kind of work where we've been trying to create resources for folks because we're getting emails from them.
Thank you. Excuse me. Okay. How can we help increase sense of client-patient safety and higher levels of care for communities facing distrust of medical systems due to past discrimination and mistreatment in addition to mental health stigma? Wow, that's a great question.
Yeah, that's a great question. Thanks for putting it on screen as well. This one is really interesting, and I wish I had a better answer. But one of the things that I have noticed, so I've been connecting with some of the folks here in Boston. It's an incredible field. I think they've got like 26 hospitals in the area. And I was talking to a resident. He's in his second year. He's a psychiatrist who works in the emergency room. And he was mentioning that most of his peers, like people on staff, are Black and Brown individuals. And he was talking about when he's been serving folks, that immediately has helped with some cases. He'd been telling me a story about a woman who has schizophrenia. She's a Black woman. And the level of engagement that he had with her, and he noticed as opposed to his attending, who's a white man, they just seem to have a slightly different rapport. And I don't know that representation alone fixes everything, but I think, again, it's another small step where people feel seen, right? Where they don't just realize they're already this outsider who's already in a spot where they're really nervous, really scared about what's happening. They might not actually understand what's happening, depending on how severely sick they might be. So to see what might feel like a familiar face, what would someone from your community or someone from your family, some kind of that proximity, that closeness, I think that immediately can kind of help people be like, oh, okay, this place might be safe. Maybe I can ask questions. Maybe I can open up. Maybe I can trust. Because the horrible thing is when people have a really bad experience, they don't want to go right back into a crisis care center. They don't want to go to the ED because they say, well, I tried it once and it was terrible. I don't ever want to do it again. But from my perspective, we also know that they do need care in some of these cases. They have to go somewhere. Otherwise, it bleeds out into the community, into the streets, into families, and you have these horrible effects. So to me, that's one thing that comes to mind immediately.
The next question, recognizing the data that indicates 50% of all behavioral health, it jumped away from me. 50% of all behavioral health disorders start before the age of 14. Can you talk about how the system and experiences are different for individuals under 18 years of age?
Oh, this is so interesting. This one, I'll be honest, I'm also a little bit less familiar with. I tend to cover more adults in the criminal legal system, but I can tell you my colleague, Hannah Fafaro, has a huge amount of stories that are coming out about youth and fentanyl. She had youth and whether or not they were able to access emergency room services, boarding. And so I hesitate to speak on things that I don't completely know about in that case, but to me, that speaks to maybe having more support at the school level, maybe earlier screenings. I know these are all things that have been talked about at the national level as well. And then again, having more discussions. Like I realize now, having covered mental health for 2.5 years, I'm the person in my family that then brings up conversations with not just my parents, but like our aunts and uncles and our nieces and nephews as well, where I'm saying like, let's talk about this thing, this elephant in the room, right? Let's talk about the anxiety or stress. Let's just call it stress, school stress. What does that look like? What is happening? Why is it happening? And then those are kind of the building blocks, as I was speaking about, that can kind of help us talk about more intensive stuff. One thing that comes to mind is the first time that I was able to learn about like passive suicidal ideation, or I forget what the other technical term it is for, like non-suicidal self-injury, which I think are all the more technical medical terms for things that might be occurring among some youth. And so having the language for that and then being able to be like, here's what the research shows, right? Here's what experts are currently saying or thinking. That kind of helps demystify that situation. Because I think when people are in crisis, there's so little bandwidth to be able to respond to things because things are so bad and you're just trying to fix it. You're just trying to get through that next hour, that next day. So that if we're able to have proactive conversations before a crisis hits, I think that might be one way to actually be able to engage with youth and families a little bit earlier.
Absolutely. What are some of the policies that have been implemented for the gap in services related to the revolving door in the system, Washington State, nationally, and what are some updates on those policies?
Mm-hmm. This is a great one. The thing that comes to mind immediately is the 988 system, of course, which, believe it or not, I have met people here in Boston who don't know what 988 is, which blew my mind because I thought we had done a good job of getting it out there. But last count that I saw, actually, most Americans do not know what 988 still is. I'm sure all of you do here because of your backgrounds, but that's something that comes to mind. I know with the 988 system, the thing that was most important to me, and granted this information is about like a year old, was getting it connected to the rest of the mental health system in the King County area. So that meant actually having some kind of internal profile where police departments, staff at the actual crisis centers, and then actual dispatchers from 988 or 911 were kind of able to share information. Because one of the other things that I noticed is, as strong as it is to have patient privacy rights, which we absolutely need, what ends up happening is sometimes that information is walled up from one organization to the other. One thing that comes to mind is a time that a police officer was saying he couldn't get any information about the client that he was trying to access. This person kept calling 911, talking about wanting to die by suicide. So he was trying to talk to them, but he didn't have any information about this person besides the fact that he kept calling like every day. And so he was trying to figure out, like, how do we access this person? How do we access this person? I wish I knew their diagnosis. I wish I knew if they had any other history of substance use disorder, or if they have any families or friends that I can call on. Those kinds of information, like, that's key to me. That's the connective tissue that's necessary. And so if in the future we have a 988 system where you're able to kind of collect more of this information, almost have this profile of a person that's calling and how to best meet their needs, that seems to me like a very successful option. I know they're currently building that and they're trying to figure out how to really get it integrated in the system. And that's for Washington specifically, not at the national level per se, but that's one that comes to mind.
Thank you. Okay. Of all the barriers you have observed, what is the biggest barrier to a functional system of care for those with the most severe and disabling mental illness conditions?
This is going to seem silly, but I think talking to each other, I genuinely think the thing that I noticed most as a reporter is how often like one arm wasn't talking to the other. And I would be the one that would be like, well, that's what they said over here. Do you think maybe you guys should like connect and talk? And that sounds, I'm sure, annoying because it's paperwork and meetings about meetings, but it's also so necessary to actually create that connective tissue again, because if it's not us that connects that for people, it's them piecing it together and families hoping that it works out for them, which is incredibly brutal. And in the worst kinds of cases, right, we have the Adams who die, who never make it through that system, or never really able to access care, stability, or recovery. They end up just getting lost there. And their families don't even know exactly what happened. With Heidi, one of the things that struck me is she was able to provide a lot of these documents, but she didn't have access, for example, to a lot of the documents from Western State Hospital or the ones that I was able to get from the prison. Thankfully, we were able to get to those through a records request. And so I handed those to her, and they were hundreds of pages that she had never seen before about her own son. And that was heartbreaking to me. That in many cases, families they barely know the diagnosis that their loved one has. They're not sure the medication they're on. They're not able to access a lot of this information. So to me, if there's a way to make sure people have that information that's consolidated, that there is cross communication, that to me is really, really vital.
I think we have time for one more question. We have about 1 minute left. How do we make these types of conversations normal in the places that matter? I always wonder what type of discussions and trainings our state and federal officials take, or if they are required to discuss these types of barriers.
That's a great question. I don't know off the top of my head for political leaders. I can tell you that our team specifically went out and got mental health first aid training just because we were so aware that we didn't have enough information. To me, I like to try to share it in other spaces as well. Now I'm a little bit more familiar with the mental health system, and in Boston, I technically cover the racial wealth gap, but this is something that I try to bring into those conversations as well when I think about mental health, access to treatment, how housing is connected to mental health as well. So I do my best to try to bring it into spaces where I know people are not already having that conversation, even if it just means I start with a really simple thing like, did you guys know what 988 is? And then we talk a little bit more about that. Mindful of time here, but thank you for letting us switch to Q&A. I just was looking out of the corner of my eye and I was like, you know what? I would rather have conversations with people who are here and wondering about things rather than just telling you about the reporting. The reporting's already out there. If you have any need to access it, let me know. I will be happy to send you a PDF or do anything else that I can to help. And as always, thank you guys so much for letting me blab for an hour.
Thank you so much, Esmy, and thank you for being flexible. There's still so many questions coming in, and I see that the chat is still very, very active. So I'm sure everybody's very appreciative of